Hello, and thank you for joining us for today's webinar. My name is Robin Walker, and I will be your program director. We are fortunate today to have three world-renowned clinical experts presenting on ways that SGRT is improving pediatrics radiation oncology, improved efficiency by reducing the need for anesthesia, skin marks, and the need for repeat imaging. By watching this webinar live, you can obtain continuing education credits for CampEP, MDCB, and ASRT. No quiz is required for ASRT or CPD Now credits. An optional survey and quiz will be available after the webinar, and your participation would be greatly appreciated to ensure that we are completing our educational objectives. For those viewing in a group session, please send your completed attendance sign-in sheet to secretary@sgrt.org. Available today is one Category A ASRT credit and one CPD Now credit. For CampEP and MDCB, to obtain these credits, please complete the quiz at the end of the webinar by the end of the day today. You will also need to answer 80% of the questions correctly and view the webinar in its entirety to be granted these designated credits. There is one CampEP MPCEC hour credit available and one MDCB credit. Credits and certificates will be distributed within 2 weeks of this webinar. The clinical experts are available live throughout this webinar to answer your questions. Please use the chat box to the left of your screen to submit your questions. The Q&A session will end at the end of the hour. First, I would like to introduce Alicia Klebik, radiation therapist, also known as the Children's Whisperer from Children's Hospital of LA.
My name is Alicia Klebik, and I'm a radiation therapist here at Children's Hospital Los Angeles. I've been here for 8 years. And today we're going to talk about the use of Align RT in the pediatric setting. So Children's Hospital Los Angeles for radiation oncology, we have one radiation oncologist, one physicist, 3 therapists, 2 nurses, front office support, and child life as needed. We have a TrueBeam, Vision RT with an MMI interface, a 6-degree freedom couch. So here at Children's Hospital Los Angeles, the vast majority of our patients are brain treatments. We also treat head and neck, neuroblastoma, Wilms, lymphomas, sarcomas, total body irradiation. We also treat keloids and heterotopic hips. Vision RT was first implemented at Children's Hospital Los Angeles in September of 2013. Initially, the therapists were very reluctant to implement Vision RT and change our workflow. It took us several months of trial and error to find the best workflow and methodology for us to use. Letting therapists have some say in how it is implemented may help to lessen the resistance. Having a champion therapist to help other therapists navigate when new technology is started may also help with the transition time. To give extra time on the machine may also help the reluctancy of therapists so we don't feel like we've gotten behind and have to play catch up for the rest of the day. Also, starting with a small patient load or a small subset of patients to lessen the load of learning in the beginning. And then once a workflow is established, and then you can implement the rest of the treatment sites. Our workflow at Children's Hospital is to bring the patient into the treatment room and position our patients in a custom immobilization device. We do use indexing for all of our patients. We use a vacuum-assisted mouthpiece for brains, head, and neck with a custom mold with a K-View portrait S-frame. We use a body fix for any other part of the body. The table is then brought to the acquired position. The patient is then set up using the Vision RT setup field. We typically use a Vision RT setup tolerance of 2 millimeters for the vert, long, and lat, and 1 degree for rotation and roll. A pitch of 2 degrees is more within our normal sometimes because of the difficulty of correcting the pitch completely. We try to minimize all of these to 0 as much as possible, but we know if a child is going to readjust themselves, we may leave it knowing that our 6-degree freedom of couch can correct this after we do the CT. After the desired setup is achieved based on Vision RT, a new monitoring reference is taken before leaving the room. After leaving the room, imaging is completed. Before we apply any of the shifts, we verify that the patient is still within those tolerances. We then capture a new reference after we apply the shifts, and that way we can monitor the patient during treatment. With the new monitoring, we can see exact amount of movement a patient is making, and it can be easily quantified. For many patients, we would get them as close to 0 as possible on Vision RT. However, we would sometimes have some deltas. This caused us uncertainty if the patient moved after we left the room or during the treatment. So for patient monitoring, we now zero the deltas while in the room by taking a new monitoring reference. And you can see on one side there's a setup which has some of the deltas still above 0, and the monitoring tab is completely zeroed out. And by doing that, we're now able to see any small shifts a patient may make. For example, if they were initially minus 1.4 millimeters and the patient were to move to a positive 1.4 millimeters, that would be a shift of almost 3 millimeters. However, it would still be in green, and it may not let us know that the shift was that large. So in order to be able to monitor both the patient and maintain a setup reference, we implemented the use of 2 fields, a setup and a monitoring. We use a setup field for initial positioning, and then the monitoring field for the rest of the treatment. When you import them, each field will have a DICOM just on the way it is imported. For our setup field, the reference image is used to position the patient daily. On the first day of treatment, we use the DICOM dataset in order to set up our patient. We capture a new reference image under setup if necessary when the films are optimal, typically the first or second day. However, we don't routinely recapture these, and we like to leave it at DICOM if possible. It may be done if a child has lost or gained weight or was bloated at simulation and now is back to what their new normal. After we have filmed, but before we apply shifts, we verify the patient is still within tolerance by using the monitoring field. We then apply the shifts and take a new monitoring reference image, replacing the in-room acquired reference to use that for treatment purposes. So at CHLA, we use Vision RT for a variety of different treatment areas, including the chest, abdomen, pelvis. We use it for craniospinal, SRS, FSRT, head and neck, and extremities. Each site has a different method of implementation to make it the most beneficial. This is an example of our head immobilization with the vacuum-assisted mouthpiece and a custom headrest. This is an example of our body fix immobilization. For our chest treatments, the chest ROI sometimes interfere with our central lines. This may happen in awake children as well, just due to chemotherapy and other treatments a child might be undergoing. So we adjust our ROIs to not include the central line. We try to wrap the ROI around laterally to at least mid-depth of the patient. We've adjusted how we make our body fix bags, and we now only make the bag to mid-depth, where previously we would make it as high as possible. For the abdomen, sometimes we have to extend it outside of the treatment area, just due to the lack of contours in this area, as well as the size of our younger patients. We also try to create the ROI at least mid-depth to give Vision RT as much information as possible. For the abdomen, ribs are a good anchor point, so we try to always include them in our ROI. So our pelvis ROIs go inferior to the umbilicus, but it's dependent on the child to how low we go. Diapers in young children limit how far down we can go. We have tucked the diapers down to the top area of the diaper to move it as much out of the field as possible. And adolescents are much more likely to resist, and we try to keep them covered as much as possible. For the pelvis, our hip bones help to anchor the ROI into place. For our extremities, we use a body fix bag for mobilization. For patients with smaller extremities just due to their age, we have to expand the ROI outside of the treatment area to capture enough surface imaging for Vision RT to be able to pick up a good area for setup. The ROI also has to wrap around mid-depth to capture the contour of the extremity. Craniospinal irradiation at CHLA is treated with Rapid Arc. Our patients are supine with a body fix bag, head fix, and a mouthpiece for immobilization. The head is immobilized with a vacuum-assisted mouthpiece and restricts the movement of the head. Limited adjustments are made on the head based on Vision RT. The ROI patch is created around the forehead and the sides of the face and will include the forehead, side of head, down to eye level. The head fix structure limits the camera visibility. When setting up our patients for CSI, we do not adjust the table, but only the patient. So our couch values are already acquired. The ROIs that we use are similar to chest and the abdomen pelvis ROIs. Because we only adjust the patient, the vertical may be left outside of the tolerance. The pitch may also be out of tolerance as well, and we have found that weight loss or constipation may be factors. If it becomes more consistent, we will take a new setup so that we can see this from day to day. We now use Vision RT along with our standard immobilization process for FSRT and SRS patients, which again is a vacuum-assisted mouthpiece and a custom headrest. Our process for an FSRT or SRS is similar. Prior to the start of treatment, the patient is set up according to the Vision RT DICOM. A new Vision RT reference is taken before we leave the room. A CBCT is performed and the shifts are applied. A new Vision RT reference is taken immediately after the CBCT and the shifts are applied. For FSRT and SRS patients, they're brought into the room and set up according to the Vision RT DICOM. A new Vision RT reference is taken before leaving the room. A CBCT is performed and the shifts are applied. A new Vision RT reference is taken immediately after applying the shifts. The couch is then rotated to any angles which are required during the treatment and a capture is taken. After all couch angles are captured, the couch is brought back to 0 to confirm that the patient has not moved. Then treatment can begin. If there is any question at certain angles, the gantry can be brought back to 0 to confirm the patient has not moved. If the camera is blocking, then a new reference can be taken. The data when taken at this point does not override any of the original data. We have found many benefits of using Vision RT at CHLA. The biggest benefit we found is a decrease in repeat imaging needed for setups. Our treatments are also more time efficient. We have eliminated all skin markings on patients. We have allowed younger kids to be treated without anesthesia due to being able to monitor them during this time. Palliative cases saw a major benefit due to them being able to come in and out quickly and not need the anesthesia. We could also use less immobilization. 22 cases we would not have been able to be treated due to the risk of anesthesia and their young age or due to their pain level. They might have been intubated, lung masses, spinal cord compression, or on the weekends, and we were able to treat these patients using Vision RT. The amount of repeated films have decreased. This happened slowly over a period of time, about 3 to 6 months, as we became more familiar and more confident with Vision RT. It took for us making adjustments to the workflow and creating a process which we all agreed upon, such as what VRT deviations we were willing to accept before filming. Tolerances for setup deviations using Vision RT prior to imaging for us is 2 millimeters for vert, long, and lat, and less than 1 degree for rotation and roll, and sometimes pitch up to 2 degrees. We try to zero these out as often as possible. Treatment setups have become more efficient since implementing Vision RT into the workflow. We use indexing, tight tolerances, and the Auto Go feature on TrueBeam, which allows us to be within millimeters of the ISO center when we take our CBCT. By using Vision RT, we are able to adjust multiple translations at once. For example, we can adjust the roll while laterally moving the patient. This has helped us become more efficient instead of moving in one direction and then having to move another way after. We now have more confidence that the child has not moved since the initial setup. Sometimes small movements are hard to be visualized by the human eye or a closed-circuit television. However, Vision RT allows us to see these smaller changes. Younger patients, 4 and 5-year-old, are now able to be more frequently done awake due to this additional confidence. Some of the benefits we found using Vision RT on CSI is we saw a large decrease in the number of repeated films. For us, visualizing and correcting the roll for the pelvis before our CBCT was the greatest help. Because we use RapidArc, the roll is very important. Many of our times for the cases are now around 15 to 35 minutes, where previously it could take 45 minutes to up an hour and a half. Our setups take, on average, from anywhere from 5 to 15 minutes, imaging from 5 to 10 minutes, and treatments 5 to 10 minutes. We are also able to better visualize movements the child has made at any point throughout the treatment. If the patient moves and settles back down, or the movement doesn't cause Vision RT tolerances to be exceeded, it gives us a confidence knowing that we are treating correctly without having to re-image the patients. For CSIs, these were our last patients to stop utilizing marks on the skin. It took us just about a year to transition for these patients to stop using any marks. The first 3 months, full marks were used and we set up with them and just used Vision RT in the background for learning. The next 3 months, we used the marks as backup. In the following 6 months, we only had the isocenter mark, but we did not routinely use it. There are several different things that caused issues in the pediatric population when using Vision RT. Some of these were the limited body contours in the pediatric population, multiple lines and/or tubes that are within the ROIs, belly breathing, increased movement in unsedated children, decreased cooperation in children, and a blanket or other covering inadvertently left on to keep the child warm. Younger children are sometimes treated with anesthesia, which adds extra lines and/or tubing to the patient, which can interfere with the ROI and give us inaccurate data. We had to adjust our patches to exclude a central line or any of the other monitoring lines that were initially in the ROI. ROIs may be larger than the treatment field and sometimes exclude part of the treatment field if it encompasses a patient's access line. This is an example of how we moved the patient's line out of the way so that we could make our ROI a little bit larger. We talked with anesthesia to make sure that they were okay with this, and we were careful not to kink the line when we were moving it up. We used paper tape so that it didn't interfere with the taping of the line. By moving the line out of the way, we were able to increase the size of the ROI. We found that children, young children especially, are more likely to be belly breathers. This can affect the longitudinal deltas with each breath instead of the expected vertical deltas. By knowing a particular child is a belly breather, we may be more aware of the longitudinal deltas that may jump more than some of the other deltas. To correct this, you can use a gated capture. However, it may not completely correct the problem. It may only lessen the extent. In these cases, we typically add 1 to 2 seconds to the beam off threshold to account for this. This is an example of belly breathing and how you can see the longitudinal deltas have moved more than the vertical. Unsedated children have a propensity to move more than adults and adolescents. Children who are not comfortable with how we have positioned them may readjust themselves. We may minimize moving them as long as they are within Vision RT setup tolerance and use a 6-degree couch to correct the remaining differences through imaging. We use Vision RT to monitor the child for any motion, and if they do move, the MMI will beam off. A blanket or other covering may be inadvertently left on to keep the child warm. By checking the Vision RT computer while setting up, we can look to see if anything, like a blanket or a piece of clothing, is within our ROI of the patient. This can lead to incorrect setup data, so it's very important to check this. Sometimes anesthesia or other personnel may cover the patient without noticing, and the patient may cover themselves as well. We look to make sure that there is nothing obvious in the field, as well as taking a treatment capture if it is necessary or if there is any doubt. Children are less likely to cooperate for many different possible reasons. A few might be that the child is anxious. The child might be uncomfortable, and then they are more likely to move. For those who fidget constantly, we give them options, such as if we are treating their chest, we may allow them to move their feet. The red lights from the camera system sometimes also cause younger children to move or become anxious. We have told them that they can close their eyes, watch the TV, or sometimes we cover their eyes with a washcloth. Explaining to them at their level what we will be doing can also decrease the anxiety significantly. Creating a mold for a stuffed animal to explain the process and show what the mold and/or the Vision RT lighting will look like may also help reduce the anxiety the child may have.
Next to present is Art Olch, PhD, Chief of Physics, Professor of Clinical Radiation Oncology and Pediatrics at the Children's Hospital of LA.
Hello, I'm Art Olch, Chief of Physics for the Children's Hospital Los Angeles Radiation Oncology Program. In this portion of the talk, I'd like to discuss our experience with going markless and removing the therapist's task of applying shifts generated from planning, all with the help of Align RT. The process starts at CT simulation, where indexed immobilization is required. No skin marks of any kind are made, and no isocenter is chosen. The only process that's taking place other than the CT scan is that the Z-coordinate of the origin of the CT scanner is set to a consistent reference point relative to the couch top. We use Eclipse and ARIA, so I'll always be referring to those systems. Similar steps might be possible in other planning and in oncology information systems. We set the user origin in Eclipse to the couch top center. This corresponds to room coordinates for the couch lateral equal to 0 and the couch vertical equal to 0. We don't change the z-coordinate acquired at the CT scanner. We enter into the field parameters in Eclipse the couch lateral, longitudinal, and vertical per the rules on the following slides. Because of the way our couch coordinates are set, we can use these transformations to go from CT coordinates to couch coordinates. This is the screen in Eclipse for the room geometry tab for the field parameters. We enter into the absolute couch positions in this dialog. The couch vertical equal to exactly the CT Y coordinate. The couch lateral is the CT negative X coordinate, and the couch longitudinal is entered from a spreadsheet calculation, which will be explained in the next several slides. The couch longitudinal room coordinate is recorded for the specified couch reference points, which is a one-time effort. Our couch longitudinal, for example, is set to 140 centimeters when the couch index position 0 is at isocenter. We use the H2 or H3 notches, which are marked by BBs on the surface of our Q-fix couch top, for targets in the body. And we use the pins on the S-frame for targets in the brain or head and neck. The Z-coordinate of the relevant location is found on the planning CT. This value, along with the Z-coordinate of the isocenter and the known room longitudinal coordinate at the reference location, are input into a spreadsheet which calculates the couch longitudinal for the isocenter and is then entered into the room coordinates dialog. Here is an example of how we find the couch longitudinal reference points on the CT scan. If your couch top doesn't have embedded BBs in the surface, you can either add them or some other identifier that will appear on the planning CT, or simply ensure that the Z-coordinate of the scanner is zeroed at a particular notch and relay that information to the planner. So for the S-frame, for our brain and head and neck cases, when the lateral laser goes through the two pins indicated by the circles on the image on the left, the couch longitudinal digital readout is 68.8. When the lateral laser goes through the 0 notch on the board used for targets for the trunk, then the couch longitudinal reads 140 centimeters. At H1, it's 126 centimeters. At H2, 112 centimeters, etc., changing by 14 centimeters from one notch to the next. After the plan is done and the absolute couch positions have been calculated and entered into the field parameters, this shift sheet is generated as a report within Eclipse and sent to the therapists. They use this to double-check the math that was used to get the couch values. They can alternatively go in the room, set the couch to the origin position, and press the Auto Go To button on the pendant and watch that the couch moves as described in this picture. In treatment, the therapist set up the patient in the immobilization device and press the Auto Couch Go To button on the pendant. This advances the couch to the predefined location. They then use the AlignRT DICOM reference surface and the AlignRT system for fine-tuning and correction of patient rotations. Cone beam CT is used to confirm the position for at least the first few fractions. The benefits of this system are that the therapists don't have to calculate the couch position on the first day based on shifts given to them from dosimetry with the patient on the table. They just push the auto go-to button. There's less chance of error. Importantly, there's no skin marks needed to find isocenter. And the patient is much happier without tattoos or Sharpie marks on their skin.
Last to present is Kenneth Wong, MD, Associate Professor of Clinical Radiation Oncology and Pediatrics at the USC Department of Radiation Oncology, Children's Center of Cancer and Blood Diseases at the Children's Hospital of Los Angeles.
I'm Kenneth Wong. I'm a radiation oncologist at Children's Hospital Los Angeles here in Hollywood, California. I wanted to talk a little bit about Children's Hospital. So we're one of the few pediatric hospitals in the U.S. with a radiation oncology facility dedicated solely to the treatment of childhood cancers and diseases. We started in 1902 with Dr. Wills, who you can see in this picture lived 12 miles away and rode on his horse into the hospital. We've had an X-ray department in our hospital since 1916, and the history of radiation oncology in our hospital begins with orthovoltage from the 1950s through 1967. We upgraded to a cobalt vault when the original Dookie building opened in 1964, and a linear accelerator vault was added in 1980, and we had a Therex 6 installed in 1982. We had a Varian 2100C, and we started doing IMRT in 2001, and we recently upgraded to a Varian TrueBeam in March 2013, and a line RT was installed about 6 months later. We've been interested in surface imaging at CHLA for a very long period of time, and we started doing little research projects in 2011. At that time, we purchased a Microsoft Kinect, and we compared CT scans versus Kinect measurements using a head phantom, and we placed BBs at various points on the head phantom, and we compared measurements from a CT scan to what we obtained from the Kinect using surface imaging, and we found excellent agreement. And for us, that generated a lot of additional interest in Align RT, and we were really looking forward to using it clinically. In 2013, this is a breakdown of the types of cases that we see. Predominantly, we see kids who have brain tumors. Next, we see children who have sarcomas and bone tumors, followed by neuroblastoma and leukemia. We also see some children who have benign conditions like heterotopic ossification or keloids. And we also see patients who have rare conditions like retinoblastoma and patients who need total body irradiation. But predominantly, we're focused on brain tumors, soft tissue sarcomas, and neuroblastoma. And so when our equipment was upgraded in 2013, we focused on what we thought would be the highest yield application. So this is a movie loop that we obtained in the summer of 2013, and it's a movie loop showing a 4D CT that we obtained on our CT simulator. This is a representative picture of a patient who had a 4D CT, and what you're seeing is our setup for this patient. So this is a patient who required anesthesia. So you can see that the patient has monitoring equipment, has a line for propofol for sedation, and has, in air quotes, pediatric bellows. And the reason we put that in air quotes is that our manufacturer didn't provide a bellows system that was sized for children. So this is our homemade solution using a pediatric bellows that we found from a polysomnograph. When we commissioned Align RT, we were happy to have Align RT for our 4D CT solution. In addition, we started using Align RT for deep inspiration breath hold for patients with Hodgkin's lymphoma. So in this slide, you can see a CT simulation of a single patient who happened to be a trumpet player. He was a tall, thin young man, and on the left, what you're seeing is a coronal CT slice, free breathing. His lung volume is 3.3 liters. And on the right is the same patient after a deep inspiration breath hold, and his lung volume has increased to 4.9 liters. So Align RT, in addition to real-time coach, is an excellent non-invasive means of achieving DIBH reproducibly, easily, and with great patient compliance. In fact, since Los Angeles is such a diverse city, we've used real-time coach successfully in patients who speak not a word of English. So in that prior example, you had a patient who was very compliant, and we found that Align RT is an excellent system even in patients who cannot comply. And in this situation, we have a 4-year-old boy who has a mediastinal mass due to a recurrent Wilms tumor who presented with SVC syndrome. So you see paired CT images of axial slices and sagittal slices, and in panel A, you see images of an anterior mediastinal mass which is encroaching upon the carina. And panel B is the size of the mass just 1 month later. And at this point, the carina is compressed to a point where intubation is nearly impossible, and the patient presented in extremis. And the patient was in the ICU. We explored various options. Ultimately, we were asked to provide palliative radiation therapy. And most people taking care of 4-year-old children in the ICU will realize that it's virtually impossible to have a 4-year-old hold still for treatment. And we puzzled about what to do. And we realized that if we used Align RT and combined that with a 10x flattening filter-free beam, we might be able to treat this patient. So the 10x flattening free beam, the beam on time was only about 10 to 12 seconds, so it was very short, but we still needed to make sure that we could reproducibly treat this patient and treat the patient safely without anesthesia. And Align RT, I believe, was the only possible solution for this. So we treated the patient using 5 fractions, and you can see in panel C that the mass did shrink, suggesting that our palliative course of radiation therapy worked really well. Unfortunately, 3 months later, the patient developed other lung metastases, and his mediastinal mass grew a little bit as well. He ended up back in the ICU with pneumonia. After his pneumonia was treated, they had a very difficult time weaning him off of the ventilator, so I was asked to treat him with palliative intent once again, this time when he was intubated on an anesthetic. And you can see in the bottom table that his treatment time was longer, not just the beam on time, but his initial setup, imaging, and repositioning. And so it's interesting that this child, when he was intubated on an anesthetic, required more time to treat than when he was just immobilized with simple immobilization in a vac lock using Align RT. In this example, you're seeing treatment for a teenager to his right foot. This is an example of a patient who is very compliant and has an immobilization system that's very tight. The body fix bag wraps around his foot and his toes, limiting the amount of movement. However, it also limits the amount of patch that the Align RT cameras can see. Despite that, the Align RT cameras are telling us that the degree of shifts is actually quite minimal. When we performed the daily CBCT guided shifts, we found that there was very close agreement. We found our modal and median translational shifts to be under 5 millimeters and rotational shifts to be under a degree. In fact, the couch shift vector length was about 2 millimeters with a range of 1 millimeter to a worst case scenario of 5 millimeters. This is also seen on the graph below. We didn't expect this level of accuracy, but this is approaching radiosurgical territory. Speaking of radiosurgery, that was the next area we wanted to investigate with Align RT. So in the image on the left, you see a child who's immobilized using our head fixation system. And this is a system that utilizes a vacuum-assisted mouthpiece device that's mounted using carbon fiber posts. We find that the head fixation system is a very rigid and reproducible immobilization system. It's often used by other facilities for radiosurgery. However, the head fixation system can obscure the region of interest for the Align RT cameras. So we performed an investigation using a phantom. At the bottom, you see 3 different graphs. On the left is a region of interest encompassing the entire face. In the middle is a region of interest just for the forehead and temples. And on the right is a region of interest encompassing just the forehead. We tested this at 5 different couch angles, replicating a non-coplanar treatment plan. And we looked at mean shifts in the 3 translational and 3 rotational dimensions. What we found was that as the region of interest got smaller, we found mean shifts to increase slightly, but they were still within about 1 millimeter and 1 degree. What we found was that as the region of interest became smaller, the mean shifts increased slightly, but they were still well within 1 millimeter and 1 degree. We found that a good balance was to include the forehead and the temples in our region of interest. After our planning study, we treated a patient using fractionated stereotactic radiotherapy for a recurrent CNS germ cell tumor. In the image above, on the left, you can see the patient's initial treatment plan, where he received 36-gray craniospinal radiation followed by a boost to the pineal gland. On the right, the patient developed a pineal recurrence, and this is his fractionated stereotactic radiotherapy plan. In the table below, we're showing the initial localization cone beam CT, and I'm showing one fractions data for Align-RT data to show that there was a great agreement between the Align-RT data and the localization cone beam CT. After the initial localization cone beam CT, we did a verification cone beam CT. Then we used intra-fraction Align-RT monitoring. And then we did a post-treatment cone beam CT. We found excellent agreement between all of the measurements, and we found that as we rotated the couch to non-coplanar angles, intra-fraction Align-RT monitoring was indispensable. In this example, we're seeing a patient who is planned using a 3-isocenter VMAT plan. This is a photograph of that patient. You can see skin marks on his chest, abdomen, and his arms. All right. So we performed a time study of VMAT CSI, and we looked at patients that we treated between 2013 and 2017. We treated 41 patients and delivered approximately 600 VMAT fractions. What we're plotting here on the y-axis is the IGRT time, or basically the time it took from the first image until we were ready to beam on. And that includes imaging for all the isocenters and time for repositioning of the patient. On the x-axis, we see the beam delivery time, and that is the time from beam on to beam off for all fields. So what you'll note is that 80% of the treatments could be delivered within 30 minutes for both imaging as well as treatment, but there were definitely outliers. In some instances, patients took over an hour to treat. Oftentimes, these were patients who developed nausea and would have to sit up and required treatment breaks between different isocenters. As you can imagine, if a patient were to sit up and required a treatment break, they would require additional imaging prior to treating them again. On the y-axis, you also saw outliers for imaging time. And what we noticed was that when we would image the different isocenters, we would image the brain, followed by the chest, and we would be happy with the results. And when we got down to the pelvis, we found that the pelvis either had a roll or a pitch or was out of tolerance compared to the brain or the chest. And so we would go into the room, reposition the patient, and re-image the brain, the chest, and the pelvis yet again. And by doing so, we found that the process was inefficient, added an extreme length of time, in some cases over an hour. Now, this is our early experience, and we're not proud of it, so we refined our processes and also added Align-RT to allow us to set up patients better, and we checked the pelvis first, then moving on to the chest, finally imaging the brain at the end. And using this model, that's how we achieved an 80% delivery time of under 30 minutes. And finally, because we have such great confidence in AlignRT, tells us how to set up our patients, tells us whether patients are moving during treatment, we've gotten rid of skin marks. So this is a patient who was recently treated, and as you can see, he doesn't have any marks, doesn't have any tattoos. While this might seem like a small thing, anyone who lives in a warm climate knows that kids love to be in t-shirts and shorts. And it was very sad to see our kids wearing long sleeves and beanies to hide their bald heads and skin marks and tattoos because they were afraid that other kids would make fun of them. And in this small way, we can provide our kids with a better quality of life, thanks to AlignRT.
Thank you for watching this webinar. As a reminder, there is no quiz required for ASRT. For those viewing in a group session, please send your completed sign-in sheets to secretary@sgrt.org.